Imagine half of all your colleagues making a suicide attempt. Because sometimes the numbers, we got to put the visual to it. And I think when you do that, then all of a sudden, I don't care what field you're in, when you say that, no, that's not acceptable. We got to do something about that. And we got to do something about it now.
In this episode of the show, mental health for physicians, specifically dermatologists amid COVID-19. This is Dermatology Weekly. I'm the voice of MDedge Psychcast's Nick Andrews. And welcome to episode 66 of Derm Weekly. Coming up later, Derm Weekly guest host Dr. Candrice Heath welcomes two psychiatrists, Dr. Nicole Washington and the host of our sister podcast, the Psychcast, and the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris. They will discuss the barriers, the importance, and the access of mental health care for physicians, especially in the midst of a pandemic. But before we get to the news, remember you can contact this show by emailing us at podcasts@mdedge.com. You can also reach out via Twitter at MDedgeDerm. We love 5-star reviews on Apple Podcasts or iTunes, and we read your reviews as well. Okay, it's time now for the latest in dermatology news. We begin this episode with researchers predicting that picosecond lasers will become more widespread soon. The picosecond laser hit the market back in 2012. It is used for treating unwanted tattoos and for pigmented lesions. Since that time, clinicians have used the technology to safely and effectively treat an expanding range of dermatologic conditions, including nevus of Oda and melasma and rejuvenation. In a review published in the Journal of Lasers in Surgery and Medicine, experts crafted an evidence-based recommendations for using picosecond lasers. Picosecond lasers currently feature pulse durations between 300 and 900 picoseconds. The researchers also called for more development of the technology behind the lasers. In the review, researchers evaluated literature that was published before March 2020 and classified 78 studies into one of the following categories: discrete pigmented lesions, other non-melasma pigmented conditions, rejuvenation, melasma, scar revision, and tattoo removal. The researchers assessed the level of evidence for each indication according to modified criteria published by the Oxford Center of Evidence-Based Medicine and proposed recommendations based on the medical literature, combined with the authors' collective clinical experience with picosecond lasers. For example, for discrete pigmented lesions, they assigned level of evidence 1A to nevus of Oda and Hori's macules, 2B to solar lentigines and freckles, 3C to café au lait macules, and 4 to all other benign pigmentary conditions. Although the fractionated picosecond laser is cleared by the FDA for the treatment of acne scars, the authors noted that rigorous clinical data on using the technology for this indication is limited. The lead author of the review is Dr. Douglas Wu, an MD PhD clinician and researcher with the company called Cosmetic Laser Dermatology. Dr. Wu and his co-authors wrote that early reports appear to suggest that the risk of post-inflammatory pigmentary alteration is low with the use of fractionated picosecond laser. This has added significance due to the high prevalence of acne scarring in skin of color. The authors conclude by discussing the laser's role in tattoo removal. This indication represents the oldest and most established dermatologic indication for the technology. The authors wrote that the accumulated clinical evidence concludes that the shorter pulse duration confers a distinct advantage when other laser parameters remain equal. They also pointed out that the evidence suggests that the shorter the pulse gets, the greater the efficacy becomes for tattoo removal. There is currently no evidence to suggest that larger tattoo particles are more optimally targeted by longer nanosecond pulses. Dr. Arisa Ortiz is Director of Laser and Cosmetic Dermatology at UC San Diego. She told MDedge in an interview that overall, this review shows evidence for slightly better improvement of efficacy with picosecond lasers compared with nanosecond lasers. She went on to say that the authors of the review also showed a slightly improved side effect profile with picosecond lasers and less risk of post-inflammatory hyperpigmentation in darker skin types compared to nanosecond lasers. However, Dr. Ortiz points out that the authors of the review did not point out one major issue: cost. The cost of a picosecond laser remains substantially higher than the cost of a nanosecond laser. She said that she is not sure the extra cost justifies the slightly improved efficacy or the slightly improved side effect profile. Dr. Eric Bernstein is director of a private practice in Pennsylvania. He told MDedge picosecond lasers offer an advantage. He said that because most of the lasers have at least 3 wavelengths, he is now able to treat patients with skin types 1 through 6. Before, he couldn't offer much help at all for patients with skin types 5 and 6 for fractionated rejuvenation and the treatment of acne scarring. But now, with these lasers, he has options for these patients. And data are coming out now about the relationship between atopic dermatitis and the historic California wildfires of 2018. During the deadliest wildfire in California history, dermatology clinics as far away as 175 miles at UC San Francisco experienced an increase in the number of pediatric and adult visits for pruritus and atopic dermatitis that were associated with air pollution that was created from the wildfire. This is according to research that was presented at the annual meeting of the Society for Investigative Dermatology that was, of course, held virtually due to COVID-19. The researchers wanted to examine whether the number of appointments for skin disease and the severity of skin disease increased as a result of the 2018 Camp Fire, which was also called the Paradise Fire. They used measures of air pollution and clinical visits in years where California did not experience a wildfire as a control. The fire spread rapidly in the fall of 2018 over a period of 17 days in mid-November, during which time PM 2.5 particulate matter concentrations increased tenfold, while the National Oceanic and Atmospheric Administration Hazard Mapping Smoke Plume Density Score sharply increased. The researchers compared data between October 2015 and February 2016, a period when there were no wildfires in California, with the data from late 2018. They collected data from nearly 3,500 adults and 700 children across a period of 3 years. In total, they examined more than 5,500 adult appointments and about 1,000 pediatric appointments for atopic dermatitis. They also compiled about 1,300 adult appointments and 300 pediatric appointments for itch. So what did they find? Let's start with the pediatric patients. The researchers report that during the wildfire, pediatric weekly visits were about 1.75 times higher, and pediatric itch visits were about 2.1 times higher. For atopic dermatitis, pediatric clinic visits increased by 8% per every 10 microgram increase in PM 2.5 concentration. Now for adults. For adults, atopic dermatitis visits were 1.28 times higher during the wildfire, and while there was a positive association between pollution exposure and atopic dermatitis, the effect is less than that observed among pediatric patients. The authors point out that an important factor in the difference between adults and pediatric patients in this disparity lies in their pre-existing diagnosis. The authors report that 80% of pediatric patients in this study with itch symptoms carried a diagnosis of atopic dermatitis at the time, while only half of the adult patients did. Air pollution was associated with the development of itch symptoms in adults, and it was also associated with more prescriptions for AD medications. However, these data did not achieve statistical significance. The authors point out the obvious limiting factors in their research, or any retrospective study for that matter, but they also argued that this can help clinical dermatologists assess how to counsel patients during future episodes of poor air quality. And they said these data can help expand the comprehension of the broad health impact of climate change. And we conclude the news portion of our show this episode with an update on COVID-19. A study that claims to be the first review of all the available evidence on the effectiveness of physical distancing, face masks, and eye protection to prevent the spread of COVID-19 and other respiratory diseases has quantified the effectiveness of these protective measures. The study, published in The Lancet, found that greater physical distancing from an exposed person significantly reduced the risk of transmission, and that N95 masks, particularly for healthcare workers, are more effective than other face coverings. The study is a meta-analysis that marks the first evaluation of these protective measures in both community and healthcare settings for COVID-19. The study reported that physical distancing of at least 1 meter, that's about 3 feet, seems to be strongly associated with a large protective effect, but that distancing of 2 meters or 6 feet could be more effective. Well, how about that? The study involved a systematic review of 172 observational studies across 6 countries that evaluated distance measures, face masks, and eye protection to prevent transmission between patients with confirmed or probable COVID-19, SARS, and Middle East Respiratory Syndrome, or MERS, as well as their family members, caregivers, and healthcare workers up to May 3, 2020. The meta-analysis involved pooled estimates from 44 comparative studies with more than 25,000 participants, and it included 7 studies of COVID-19 with 6,600 participants. None of the studies included the meta-analysis were randomized controlled clinical trials. The sub-analysis of 29 unadjusted and 9 adjusted studies found that the absolute risk of infection in proximity to an exposed individual was 12.8% at 1 meter and 2.6% at 2 meters. The risk remained constant even when the 6 COVID-19 studies were isolated, and it remained constant regardless of being in a healthcare or a non-healthcare setting. Each meter of increased distance resulted in a doubling in the change of relative risk. This finding was statistically significant with a p-score equal to 0.041. The analysis also examined PPE, including N95 masks. The researchers found that the masks were associated with a large reduction in infection risk at 3.1% with a face mask, compared with more than 17% without a face mask. The association was stronger in healthcare settings compared with non-healthcare settings. That was also statistically significant, with p equals 0.049. The researchers also looked at barriers to social distancing and called for more high-quality research, specifically randomized clinical trials of the optimal distance. The goal of the research was to help inform WHO guidelines. And that concludes this edition of Dermatology News for episode 66 of Dermatology Weekly. Derm Weekly. We'll be right back after this. Welcome back to episode 66 of Dermatology Weekly. It's now time for the peer-to-peer portion of the show. Please welcome our guest host, Dr. Candrice Heath, and our guests, Dr. Nicole Washington and Dr. Lorenzo Norris.
Joining me are 2 psychiatrists today, Dr. Lorenzo Norris from George Washington University in Washington, D.C., who is also the host of the MDedge Psychcast, and Dr. Nicole Washington, who is Chief Medical Officer of Elosin Psychiatric Services, a telemedicine practice providing care to physicians and other professionals around the country. Thank you both for joining me today.
Glad to be here. Great to be here, Dr. Heath.
Yeah, thank you for having me.
So, over the last several years, many people across a variety of careers have begun to really publicly acknowledge the importance of mental health. Unfortunately, as you know intimately, in the physician population, there are still a lot of taboos about talking about our own mental health. Dr. Washington, when physicians finally do seek help with you, what are some of the mental health disorders that you are seeing frequently in your physician population?
Well, as with the general population, anxiety disorders are by far the most common disorders that we see. And I do see quite a bit of anxiety and depression in the physicians that I take care of, as well as substance use issues.
And Dr. Norris, do you have anything to add to that?
Well, absolutely. I mean, those conditions in terms of depression, anxiety spectrum disorders, but particularly substance use disorders, these are the things that we're actually seeing in the physician population. And I want to put a particular point on, if you will, the unipolar depression, as well as the substance use, because we know that those two things in regards, that's just a very lethal cocktail. And I would say even before we start to see depression as well as substance use, we have to be vigilant to, for lack of a better word, syndromes of distress. You can conceptualize this as a bit overused now, but it has a certain relevance or teeth to it, burnout. The other concept that I think actually has a lot of utility is demoralization. A good way to think about it for me is that burnout and demoralization are either precursors or pre-syndromal to depression and substance use. So we need to really be intervening at an earlier stage before we let physicians get to the point, if possible, to the point of either having a unipolar depression or a substance use. And I thought Dr. Washington did a very good job also of highlighting anxiety, because we're really, what's the bottom line? Physicians have a higher rate of suicide than the general population, and the association with anxiety as opposed to depression. Anxiety is a really big deal when it comes to not only suicidal ideation, but completed suicide.
So most of our listeners are going to be dermatologists, and our dermatologists, or dermatologists to be, You mentioned unipolar depression. Can you explain a little bit more
Sure.
about what that is?
Absolutely. Unipolar depression, that's just my way of saying major depressive disorder. All right.
Okay.
There's major depressive disorder, there's bipolar disorder. Depending on who you talk to, there's a lot of different ways to conceptualize it, affective spectrum disorders, but I'd say unipolar depression specifically for that reason, that it's major depressive disorder. So you can use those two terms interchangeably.
Oh, okay. Okay. Thank you for that. We're dermatologists, so we don't often speak in those terms, but thank you so much for educating us about that. So you mentioned physician suicide. Again, yes. Another taboo topic that is definitely making headlines right now, as there have been a number of physicians who have committed suicide, which really I think is more of an ultimate cry for help than anything else. Can you give us an idea of how prevalent this physician suicide may be?
And the key word that you said, Dr. Heath, is can I give you an idea? Because that's the best I can do. I can only give you an idea. We estimate that roughly about 300 to 400 physicians commit suicide every year, but that's just an estimate because we really don't know. We don't know the numbers because it's very difficult to track or to report, but that would be the estimate. So what does that usually equate to? That equates to 2 large medical school classes. One thing that I usually tell folks when I think about physician suicide, the graduating classes of Howard, GW, and Georgetown replace all the physicians that die by suicide every year. That kind of gives everybody an idea of the magnitude of this problem. When we're talking about physician suicide, we can talk about suicide rates. We can say that male physicians are 1.41 times higher than the general male population to commit suicide. And in our female physician population, they have a 2.27 increased risk of suicide. So the unfortunate thing about this is that we can only give estimates in regards to the true prevalence of suicide. We can say that the syndromes that Dr. Washington pointed out, whether it's major depressive disorder, well as generalized anxiety disorder, whether it's substance use disorders, we're having a better appreciation of what those numbers are. But physician suicide has been certainly a problem. It's been on the rise, and I would dare say it has actually paralleled what we are seeing in this country, where we've had an increasing level of suicide rates for a decade plus. So as our patients go, physicians have gone too.
That is really definitely eye-opening. Dr. Washington, I know that one of your areas of expertise is around physician mental health specifically. What would you like to share about physician suicide?
I think that's a great thing for us to remind ourselves is that this is a guess and an estimate, and that 300 to 400 number, we think we're in the ballpark. And one of the things I try to get people to think through, if there are that many who actually complete, how many more are there who walk around with the thoughts daily who don't complete? How many are there who we don't include in the numbers that we have as far as the anxiety and depression and substance use? Because that relies on either them admitting to it or seeking treatment for it. So the numbers, I think, are much larger. And I think that we are guessing a lot when it comes to this because it's just not something that we have been able to put our fingers on and come up with firm numbers for.
We can actually just think about this. We know if we look at the national data in the US on suicide rates, that there's roughly, I'm going to say, 30 suicide attempts per completed suicide. So if we take that 300 or 400 number that Dr. Washington just talked about, and she just laid it out for you, that's 9,000. That's 9,000 attempts. So 9,000 people would have attempted and 300 to 400 would have completed. I mean, so yeah, that brings to the scope of the problem. And I mean, since this is the dermatology podcast, which is good, we just had a number of medical students graduate, entering into the field of dermatology. I haven't actually looked at the numbers, but I'm just kind of curious just how many dermatologists are actually out there practicing.
There are about 14,000 dermatologists in practice right now.
So about 14,000 dermatologists in practice right now. So if Dr. Washington and I's crude calculation is correct, are you sitting here telling me that like approximately it would be the equivalent of more than half of the dermatologists in practice making a suicide attempt? I mean, that's what it is. Like just so people can like put their mind around it. Imagine half of all your colleagues making a suicide attempt. Because sometimes the numbers, we got to put the visual to it. And I think when you do that, then all of a sudden, I don't care what field you're in, when you say that, no, that's not acceptable. We got to do something about that. And we got to do something about it now.
Yes, I think that's a great comparison, definitely, to think about losing that many colleagues to suicide. That is massive. Speaking of colleagues, every day in the news, we hear about healthcare workers and what they're doing on the front lines. What should physicians on the front lines really be doing right now during COVID-19, the pandemic, to protect their mental health?
Now, first off, there's a lot of great information out there in regards to the stressors of pandemics, the stressors of quarantine. And our colleagues, whether folks in the Department of Defense or the VA, they've done a lot of work on this. And I would encourage people to look at some of the guidelines that have been released in regards to PTSD. But I think one of the first things that people can do in terms of their own mental health is you got to know the stressors. You got to know the stressors and you got to know the time frame. All right. Now, depending on what you consider COVID-19, you can use a disaster response model, okay? This has been put out there before, but there's usually, if you will, anywhere from 4 to 5 phases of it. I'm gonna say pre-disaster, impact, heroic, honeymoon, disillusionment, and reconstruction. All right, so you gotta know what phase you're in. Another simple way to do this is, are you surging, are you plateauing, are you peaking, or are you going down? All right, that's kind of another simple way to do it. And then once you know that, once you know where you're at, then you have to know the main areas of stress that people are gonna face. One is going to be your biosecurity. A good way to think about that is like PPE, physical strain, and the level to be constant awareness of. The next stressor you're going to face or category is going to be risk of disease transmission. And then the other stressor that you're going to have is balancing the multiple medical and personal demand stressors, because many of us in this era now, we've gone to telehealth and things of that nature. We're trying to balance homeschooling. We're trying to balance our own life with our own family members. We're balancing a lot of different things, but when all of those things come together, that can become a great difficulty. So again, the way I think about it is, where are you at? Do you understand what particular stressors affect you? And then clearly being proactive about your mental health. That's just kind of a broad overview in terms of how you can start to think about it.
Dr. Washington, what would you say are some of the things that, the doctors and the healthcare workers who are on the front lines during this COVID pandemic, what are some of the things that you are telling your patients?
We are working on 2 main goals. The one thing we talk about constantly is controlling the things that we can control. In medicine, we are used to trying to control every little detail and know everything we can ahead of time. And this is just not something that any of us have been prepared for. So the uncertainty, the lack of control is really, really affecting a lot of us negatively, understandably so. And so focusing a lot of energy on things that you have no control over lead to a lot of anxiety, and you feeling stressed, and you feeling more fatigued, and you feeling more defeated. And so we focus a lot on what are those things that you have control over about your day? What are those things that you can control? We look back at what are those things that have helped you make it through tough, stressful times in the past? And can we use some of those same things to help you now? Which of those things are not effective that we need to replace? And so we do focus on that. And then we focus to getting to that final phase of that reconstruction or that acceptance, right? When you think about the 5 stages of grief, or whether you're looking, at other models, getting to that acceptance is where you can then go, okay, I've made it through the other phases. I have a clearer picture of where I am, where I need to go, and what it takes for me to get there. It may not be a perfect situation. It may not be something I anticipated, but now that we're here, how do I take acceptance of the situation I'm in, and how do I try to move forward without it completely taking me down?
And Dr. Washington, if you can go on to add some comments about some of the things that physicians who are not on the front lines, how can they be mentally impacted by the COVID epidemic? I think there's a lot of focus on those who are on the front lines, who are really risking their lives, their families' lives, all of that. But what about those other physicians in the background? What's happening with their mental health, and how do you think that the COVID pandemic has impacted them?
A lot of physicians are facing financial difficulty, whether you're frontline or not. And a lot of those physicians who are in private practices or you're in a different specialty and you're not necessarily frontline. A lot of those doctors are seeing pay cuts or furloughs because they aren't bringing in the same revenue that they brought in because everybody's staying at home and nobody's coming in, and we've restricted a lot of contact. And so the financial stress that a lot of people are seeing is taking a toll. I've seen quite a few physicians who their financial security questions are now creating some anxiety that wasn't there before. And so that's part of it. I'm also seeing, surprisingly, because this isn't something that I anticipated seeing, I'm seeing physicians who are feeling guilty. They are feeling as if they're watching their peers jump in and be in the game and in it, and they're just kind of sitting on the bench. And I've had multiple physicians talk about the guilt that they feel, or feeling as if they aren't doing enough, and really being harder on themselves about their lack of action on the front lines. And that is affecting their mental health as well.
Wow, that's definitely quite a concept. Dr. Norris, what do you have to add?
I agree actually with everything that Dr. Washington said. The economic impact is very real. Many groups or institutions at this point in time are really having to make very difficult decisions. So Dr. Washington was absolutely accurate, in my humble opinion, with that. I would say I am seeing a bit of the guilt. I certainly also am seeing that from our wheelhouse here in GW in regards to maybe they should be doing more. And then the other thing I would say that I think that, because it's interesting that we use this frontline concept, I think that there are those that are on seeing COVID patients. I mean, I certainly am in the hospital seeing COVID patients, but many of my colleagues, even though they're not necessarily seeing COVID patients, their workloads have increased tremendously. It's weird. It's like the volume has gone down, but the stress of everything and meetings and constant information and education has gone up. So I kind of like to think sometimes COVID is everywhere, and it just kind of depends on how, in which shape or form you have to deal with. And why do I bring that up? I think that there's the guilt, but I also think that can get underappreciated. The amount of work that people are doing to really keep, for lack of a better word, maybe the outpatient division afloat. So, yeah.
Yeah, I think that all of those are great points as well about physicians not necessarily directly dealing with the COVID happening on a day-to-day basis at the hospital, but all of those other things that they're doing and now that they're responsible for, that does, take a toll on them. So it is definitely okay to acknowledge that change in your life. And speaking of life changes, over the years, I've often read these surveys about, which specialty physicians are the happiest and most content. And often dermatologists top the list, or in the top 3 or 4 of all physician specialties that are among the happiest. Then COVID happened, and I'm sensing that there's definitely some stress going on, even in the dermatology community. So what can dermatologists do to protect their mental health during this pandemic, especially considering all of the other things that you said to answer the previous question? Dr. Norris, do you want to dive into that one?
I guess I would start with the idea. I mean, the first thing that I think about is it gets at the idea of what Dr. Washington was getting at, control. Know what it is that you can or cannot control. I think knowledge is very powerful in terms of educating yourself, in terms of what to expect. That's what I was talking about. The biggest thing in terms of people protecting themselves, whether it's a dermatologist or anyone else, I think that it's still the same stuff. Being willing to reach out and get assistance. If I had to pick one thing, really be mindful of yourself and where you're at, and do not hesitate to reach out and get assistance, professional assistance, even if you don't feel it. But if you were under financial distress, if you were under a great deal of duress, I really think the biggest thing is to actually reach out and get professional help. To me, that's one of the number one barriers in regards to physicians, is that they do everything too late. They try to control everything, including themselves. So to me, the biggest thing dermatologists can do, and any physician for that matter, I mean, we can maybe get a bit more specific, but I have to start with reaching out. I just have to. And being honest about where you're at. Being honest and reaching out.
Yes, I guess it's the same concept of putting your own oxygen mask on first to say, oh, there's a problem, I need to take care of myself, and then moving on to the other things. Dr. Washington, do you have anything to add?
I do. I think you hit the nail on the head earlier when you talked about in all these surveys, dermatologists are seen as the happiest. And I think in medicine, dermatologists have a certain, there's a certain reputation that goes with being a dermatologist. And, people make their jokes about, man, they got it made. And, you make all your jokes about different specialties. But I think dermatologists specifically, because they have historically been a specialty that is, well compensated, and they tend to be happier, and the lifestyle, is there. I think those doctors are at increased risk of feeling guilty about even pursuing treatment, because they think, well, what do I have to be bothered for? Because I really do have it good. Like they feel bad about even saying that they're having a hard time right now, when in reality, we should all just be feeling whatever it is we're feeling. Like, feel your feelings, figure it out, and reach out, and don't let your circumstances or what you think people see as your circumstances stop you from reaching out.
Yes, I think that's great advice. Dr. Norris, did you have something else to say? I heard you.
No, I was just nodding enthusiastically. Absolutely.
Oh, okay.
Yeah, absolutely. No, I mean, yeah, that's the truth. Yeah, absolutely. No, preach on. No, say that again. I mean, that's Washington put it out there for you, no doubt.
So now everybody has a new normal. No one is excluded in the world. We all have a new normal. So for physicians, the transition to this new normal can be a unique one. So do you have any words of advice for physicians in general transitioning to this new normal, whatever that may be for them? Their practice is not going to be the same for a long time, and it may never go back to how it was before. So talk about just the unique impact of the world's new normal on physicians. I don't, Dr. Norris, do you want to take that one first?
Sure, I'll jump into that one. I mean, I just got really 2 words for folks, radical acceptance. It's a term used frequently. It's a part of DBT therapy. It's something that I firmly believe in. I'm with the people there. It's a new normal. I mean, you go home, you work, and like, who knew homeschooling could be so hard? I mean, it's rough. It's real. It's not. Yeah, I see people not. Yeah, it's tough. I mean, who knew geometry's hard, man? So is history and all that stuff. But you think about this, and I'm with my family, and they're like, okay, yeah, I can't wait till we get back to school. I'm like, I'm not so sure about that. Maybe you will, maybe you won't. Maybe it'll be a hybrid. But if we stay in a state of denial, and we keep trying to think that it's going to go back to what it was, that's just not going to be adaptive. I mean, one of my attendants had a saying that, reality is your friend, and it's the only thing that's going to help you. So for me, you just have to, in terms of that new normal, you have to radically accept it. And what does that mean? That means you don't judge it. That doesn't mean you have to like it. It doesn't mean you have to feel one way about it, but you have to just accept it for what it is. And once you do that, then I think you're in a better position. Otherwise, you're going to just suffer.
And Dr. Washington, what advice would you give?
I think you're right that both professionally and personally, we are going to see a lot of new normals and transitions. And I think it's important for us to show ourselves a level of grace. I see physicians who are trying to be, the homeschool teacher plus the summer camp counselor, and they're trying to cover all the extracurriculars and still take care of their patients. And, there will come a point where I think we will have to show ourselves some grace and realize that there are going to be some days where we don't do as well as we think we should do, because we all have very high expectations for ourselves. We would never have gotten to the point where we are in our careers if we did not. And so this is going to really hit us in a place where we're going to have to accept the fact that we are not superheroes, and we are human, and we have limitations, and our expectations of ourselves are really going to have to, be put in check here in the next several months.
I totally agree with that. And I just want to close by saying thank you so much to our guests, Dr. Lorenzo Norris and Dr. Nicole Washington, for discussing mental health on our special COVID conversation series. I am your guest host, Dr. Candrice Heath. Be safe and be well, both physically and mentally.
And that's it for this episode of Derm Weekly. Derm Weekly is produced by MDedge Dermatology editors Melissa Sears and Elizabeth Meshkati. The peer-to-peer portion of the show is produced by Melissa Sears and hosted this week by Dr. Candrice Heath. Our guests were Dr. Nicole Washington and Dr. Lorenzo Norris. The news portion of the show is produced by Elizabeth Meshkati. The stories were originally reported and published at MDedge Dermatology by Doug Brunk, Jeff Craven, and Richard Mark Kirkner. All MDedge podcasts are produced by our editor-in-chief and the editor-in-chief of Medscape, Dr. Ivan Oransky, as well as MDedge executive editors Kathy Skarbeck and Mary Ellen Schneider. Multimedia editor Terry Rudd, and social media is produced by Kyla Clark. Dermatology Weekly is edited, engineered, and produced by Tyler Mundek. For all of us here at MDedge, I'm Nick Andrews. You're listening to Dermatology Weekly.